السلام عليكم ورحمة الله وبركاته. Again, this is the second part of the lecture named Rheumatoid Arthritis by Professor Dr. Abdelazeim elhefny. In the first part, we finished the RA definition and pathogenesis. In this part, we will focus on the clinical picture, the symptoms and signs, and how to diagnose a case of rheumatoid arthritis, and how can we use the 2010 classification criteria for rheumatoid arthritis classification. These are the ILOs where if you want to revise the diagnosis. Now, what are the features of rheumatoid arthritis? Joint pain, joint swelling, morning stiffness affecting the small joints of hands, feet, and wrists, more than half an hour. Symmetrical joint involvement, especially the small joints are affected early than the large joints. Systemic features like fever, fatigue, malaise, and myalgia, and also extra articular features which we will discuss later. Which joints are affected in RA? Rheumatoid arthritis sits into smaller joints in asymmetrical distribution first, such as metacarpophalangeal joints here and proximal interphalangeal joints, wrist or toes. Later on, it can spread to the knees, ankles, elbows, shoulders, neck, and hips. Sparing the distal interphalangeal joint, the first carpometacarpal joint, thoracic and lumbosacral spine. This is a hand of rheumatoid arthritis patients. As we see, there is swelling in about all the proximal interphalangeal joints and the metacarpophalangeal joint, especially the second one, and sparing the distal phalangeal joints as we see in the picture. Here, there is hand deformities which can occur later on in the course of the disease, causing boutonniere deformity of the ring finger as we see, which causing hyperextension of the distal interphalangeal joint and flexion of the proximal interphalangeal joint. The picture to the left side, but the picture in the right side showing swan neck deformity in the index and middle fingers. This is the swan neck in the form of flexion of the distal interphalangeal joint and hyperextension of the proximal interphalangeal joints. Also here in this patient, there is ulnar deviation at the level of the metacarpophalangeal joint bilaterally. Here, many pictures in many patients with long-standing rheumatoid arthritis and hand deformities. The one to the upper to the left, as we see, there is wasting of the interosseous muscles, small muscles of the hand, of the dorsum of the hand. The upper to the right, there is ulnar deviation and also wasting of the interosseous muscles. The down picture to the left, there is Z deformity of the thumb, and to the right in the lower picture, there is subluxation of the wrist joint as we see. In these rheumatoid feet, the upper to the left side, there is hallux valgus in patient with rheumatoid arthritis, causing lateral deviation of the thumb due to subluxation of the first metatarsobphalangeal joint. The picture upward and to the right, there is hook up tooth or hammer tooth when in patient with prolonged rheumatoid arthritis with two deformity. There is hyperextension of the metatarsobphalangeal joints and flexion of the interphalangeal joints. The downward picture shows hallux valgus with overriding of the tooth. Also, the shoulder can be, or the elbow, or the other joints can be affected with swelling due to effusion, excessive accumulation of synovial fluid inside the joint capsule. It will be swollen, tender, and hot with limitation of movement of the affected joint. The upper picture to the left, this is the elbow, swollen elbow with effusion. The upper to the right, there is effusion and it's causing swelling of the right shoulder. The downward pictures or both shows knee effusion. What are the extra-articular manifestations of rheumatoid arthritis? If we can show these manifestations from up downwards, we can see most of the organs can be affected from upwards from the eye. There may be scleritis, conjunctivitis sicca. There is much dryness of the eyes with episcleritis also. When we spread to the lower downwards, there may be atlantoaxial subluxation if there is affection of the joint between the first and second cervical spine. Also, there may be affection of the heart causing myocardial infarction or asymptomatic ischemic heart disease. Pericardium may be affected, causing pericardial effusion. The lung can be also affected with interstitial lung disease, fibrosis, or nodules or pleural effusion. Lymph nodes may be enlarged with reactive lymphadenopathy. The spleen may be enlarged, causing splenomegaly, especially in Felty syndrome, which we will discuss later on. The kidneys, as it is chronic illness, can be affected by amyloidosis, causing nephrotic syndrome, or also can be affected by treatment of rheumatoid arthritis, especially with nonsteroidal anti-inflammatory drugs. There may be rheumatoid nodules or vasculitis or palmar erythema in the hands. Amyloidosis can also affect the gut. The median nerve may be compressed in the wrist, causing carpal tunnel syndrome with tingling and numbness in the distribution of the median nerve. If left untreated, it can cause thenar eminence atrophy. Muscle wasting can occur due to disuse of the muscles nearby the affected joints. Also, the bone marrow can be affected, causing anemia and or thrombocytosis. The skin may be affected in some patients for thinning and ulcerations. Peripheral neuropathy, monocytosis can occur also. These two pictures shows rheumatoid nodules. It is subcutaneous nodules, most commonly situated over bony prominences, as we see in the elbow or the dorsal of the hand, but also observed in the bursae and tendon sheath. It is firm, non-tender, freely mobile. Nodules are occasionally seen in the lung, sclera, or other tissues. Nodules correlate with the presence of a rheumatoid factor, as most of the other extra-articular manifestations. Remember that all patients with rheumatoid nodules are seropositive, and also are the disease in these patients are aggressive. This is lung X-ray, plain X-ray, posterior anterior views. In the left one there is pleural bilateral pleural effusion. On the right one there is these nodules, lung nodules, these opacities due to lung nodules bilaterally. Felty syndrome. Risk factors for Felty syndrome: the age of onset between 50 to 70 years, female more than males, Caucasian more than blacks, long-standing RA, deformities but inactive disease are present, seropositive for rheumatoid factor. Common clinical features in these patients: there is splenomegaly, lymphadenopathy, weight loss, skin pigmentation, keratoconjunctivitis, sicca, vasculitis, leg ulcers, recurrent infections, and subcutaneous nodules. In the laboratory findings of these patients, there may be normochromic normocytic anemia, neutropenia, abnormal liver function, thrombocytopenia, impaired T and B cell immunity, vasculitis. This is the end of the second part of the lecture, and we will proceed nearly to the third part, and thank you.